Good morning, good afternoon, good evening, wherever you are. My name is Louis Bond. I will be your host today. I'm the chairman of the ReSViNET Foundation, and today it's my honor to chair the webinar with our distinguished speaker, Juan Pablo Torres, who I will introduce in just a second. So the mission of ReSViNET Foundation is to support the performance of high-quality research to improve knowledge of RSV epidemiology and to support the development of preventive and therapeutic interventions and global implementation strategies. And we have the vision to connect global expertise and leadership in order to decrease the global burden of RSV infection. And our goal is to advocate for and create awareness of the RSV. We combine knowledge and capacity required to enhance the development of novel RSV therapeutics. And today is our 18th webinar, The Effectiveness of RSV Prevention Strategies. Real-world data, or recent data, or impact data, whatever you call it, is really going to be an exciting moment today. Before I give the floor to Juan Pablo, I would like to remind you that you can use the Q&A chat for submitting your questions. So please do so during the webinar. While he is speaking, I would invite you to ask your questions so that facilitates the Q&A session after Juan Pablo finishes his lecture. So without further delay, I would like to introduce Juan Pablo Torres. He is a pediatric infectious disease specialist at the Faculty of Medicine at the University of Chile at the Hospital of Luis Calvo Mackenna. He's the Vice Dean of the Faculty of Medicine, and he's a researcher at the Institute of Complex Engineering Systems, ISCI, in Chile, and is the Vice President of the Latin American Society of Pediatric Infectious Diseases. Without further delay, Juan Pablo, the floor is yours.
Okay, thank you very much, Dr. Bond. It's a real honor to be with all the friends from the ReSViNET and be here today in this ReSViNET RSV webinar. For sure, I agree that there's a lot of amazing and incredible information regarding the prevention of this infection that is one of the worst infection for our infants. So moving forward to the webinar, the idea is to review very recent data, and especially focusing in effectiveness of RSV prevention strategies that is coming from of course, I will focus of the information and the data from my country in Chile, but also in another countries that are giving very relevant information about the RSV prevention. So this is my conflict of interest slide. And all the results presented in the Chile NIRSA-CL study, I would like to emphasize that no funding was received for this, the implementation and also the analysis and the data of this strategy in my country. So just probably most of you know, nirsevimab, the monoclonal antibody, was introduced in some developed countries in the northern hemisphere during 2023. But in the southern hemisphere, Chile was the first country to implement a universal countrywide immunization strategy with monoclonals that started on March 2024. So the idea is to report and share with you the first, this is national level impact and effectiveness results of the strategy up to the entire 2024 season in my country, in Chile. So just to let you know how is the seasonality of RSV in Chile and also in the South Cone of South America, like Argentina, Uruguay, Paraguay, and Chile. Most of our countries have a very clear seasonality for RSV, and the peak used to be during July. July is our worst month in the year where the RSV peaks every year, and we need to elaborate and implement every year a winter campaign to try to attend in the best way our infants in the pediatric wards, in the ERs, and also in the pediatric intensive care units. So one of the things that probably helps Chile, that is not a developed country, to be able to implement a monoclonal universal strategy for RSV was something that was coming from the pandemic of the SARS-CoV-2, and was the availability to work in a transdisciplinary way together with the Ministry of Health and also with the academics from the University of Chile and the Institute of Complex System and Engineering. That means engineering with a high capacity of analytics that are part of an excellent center that is founded also by the Ministry of Science in Chile. It's a public founding institution. And we were able in some way to combine the provider of the monoclonals, because Chile was in a schedule for 2027 to have some doses available. But in the way that Chile were able to have the possibility of having pre and post intervention data, and we were able to measure the impact, probably the provider interest increased. And finally, we were able to convince also the Ministry of Health to move forward to a national campaign prevention strategy with nirsevimab. Before the decision was taken in my country, we have to run a national cost effectiveness study that is already published. And the bottom is the reference. But the idea was that in the first month of the 2023, the engineers, together with academics and also with the Ministry of Health, they were able to work together to put all the database from the national discharge, from the national registry, and from the electronic immunization record, to be able to talk each other in order to have the best data to do, for example, this cost effectiveness study. So this cost effectiveness study was not a model, was real data from the season 2019, 22, and 23. And here we evaluate and estimated how many bed days from the pediatric ward, from the PICU, from the major emergency department could be avoided if every season we use the monoclonal antibody. So, and also in the figure D, we can see a cost effectiveness analysis, and we were able to estimate that if we consider only the direct cost involved in this strategy, and we include in the national strategy all the newborns during season plus the catch-up with a catch-up group. That means infants born before or with less than 6 months of age when we start the strategy. This strategy could be cost saving, just in the limit, but could be cost saving. So with all of this information, finally, the idea was to start a national strategy with monoclonal antibody, in this case with nirsevimab. Who was immunized during the campaign in Chile? Well, 3 groups. First, all the newborns during season. So that's occurred in the maternity wards between April 1st to September 30 during the year 2024, including around 80,000 infants. The second group was the catch-up group, all infants under 6 months of age. This was defined, all the infants born since October 1st, 2023. This campaign was done not in the maternity ward, was done in all the vaccination sites, in the public and private vaccination site, because this is a strategy funded by the state, so was free of charge, and the infants can go with their parents to any private or public vaccination site to receive free of cost the dose of nirsevimab. And the third group was the historic high-risk infant receiving palivizumab. That during the year 2024, palivizumab was completely replaced by nirsevimab, and this high-risk group can receive the dose of nirsevimab during the first and also during the second season exposed to RSV. Well, here is the evidence. When we start the campaign in Chile was on March 26. Here is our Ministry of Health, Dr. Jimena Aguilera, with the Vice Minister Minister of Health of Chile. And here you can see that Samantha, and in the opposite bed, Santiago, were the first two babies that were immunized with nirsevimab in Chile, but also in Latin America and in the Southern Hemisphere. Also, I like this picture because it shows how the Minister of Health and this transdisciplinary group was working together. Here is Dr. Leonardo Basso, that was the chief and well, part of the genius of the engineer team that make all the analysis from the EC Institute. So all of us working together to implement the strategy. And this started in a very poor hospital that is located in a special part region in Santiago, our metropolitan region, the capital city in Chile. So how was the uptake of the nirsevimab strategy? Here you can see the dynamic. First on yellow, you can see how was the dynamic from April to October for the newborns during season. It was very homogeneous and was very high, 97.5%. We, in some ways, expected a result like this because our coverage for the hepatitis B and BCG vaccine that is already delivered in the maternity wards when the infant's born, it's around 98%, 98% of coverage. The most challenging group was the catch-up group, the infants born since October 1st. And here you can see that it takes us 2 months during April and May to see if we, to obtain finally a coverage in the catch-up group that also was very high, 90% was achieved. So the overall uptake of nirsevimab in Chile was 94%. One question that we have during the last campaign is this uptake, especially in the catch-up group, was on time regarding RSV circulation in the country. And here you can see all the epidemiological weeks and how was the circulation of RSV based on the national surveillance of RSV that is made by our national reference center, is the Instituto de Salud Pública. And you can see that during April, that the coverage in the catch-up group was around 50%. We didn't have much circulation of RSV. During May, that the coverage of NIRS in the catch-up group achieved around 80%. The RSV was starting circulating. And during June, that we have RSV circulating, the coverage of nirsevimab in the catch-up group was already around 90%. So I think that the coverage in the catch-up group was more or less on time regarding RSV circulation in the country. What about nirsevimab safety? Now it's available, a bulletin from the Instituto de Salud Pública that make a great job regarding that. And you can see that after more than 163,000 doses of nirsevimab was administered in the country, we have 18 reports of SAVIs that represent a report rate of 1.1 per 10,000 doses. Only 4 of these from these 18 SAVIs were severe. All of them were reviewed by the committee in charge of that. And finally, only 1 of these SAVI was considered consistent with the nirsevimab, that was a local adenopathy close to the site of injection of the monoclonal. So in general, we believe that during the campaign in Chile in 2024, nirsevimab was a very safe product for our population. So let's see the results. First, the impact and then the effectiveness. Regarding impact, here is just to have a general idea. This is the weekly report of our authorities in the Ministry of Health that reports the PICU national bed occupancy. And this is the report. The letters are small, but this is picked when the report was made in the mid-July. That used to be our worst month during the winter campaigns because of the RSV. And here you can see that the bed occupancy, PICU bed occupancy in the private and also in the public system during July was only 70%. This was very unique because usually we have over 100% of PICU occupancy during July. But probably one of the most important achievements regarding the impact of the RSV national campaign, I think, is related with the cases of death associated to RSV in children or infants less than 1 year of age. So usually we have between 13 to 15 cases of death associated to RSV every year in Chile. And of course, this number could be probably underreported, but the official number of cases of death associated to RSV is between 13 to 15. And during the campaign 2024, no cases of death were reported associated to RSV in infants less than 1 year of age. So clearly, here is a result that is very, very relevant regarding the campaign, prevention campaign or RSV in the country. If we move to another outcome now, not the death, is the severe lower respiratory tract infection. In Chile, we have a surveillance network in different hospitals that test with PCR all these cases when they are admitted. And here you can see the cases of severe lower respiratory tract infection because of RSV in children less than 1 year of age. And here you see the situation of severe LRTIs during the year 2019, so pre-pandemic, in the year 2023. And what happened after Chile started the monoclonal strategy, the national prevention strategy, and you can see how the curve is more flat, and especially the bars in color blue and in color orange tends to disappear. And these bars corresponded to the 0 to 3 months of age cases and the 3 to 6 months of age cases, so was part of the eligible population for the to receive nirsevimab during the strategy. So probably this is a second result of impact in the real world that the severe LRTIs in the country decrease, especially in the eligible group for nirsevimab. So also in a collaborative work with the Ministry of Health, the Instituto Sistemas Complejos, and the Faculty of Medicine, we were able to implement a similar platform, public and open platform, similar to NIRSE-GAL, the platform created by Dr. Federico Martín Torres. He knows about the idea to have a similar platform in order to compare data. And if you enter to this web address, www.nirse.ec.cl, the information is available, and you can see and select different age range, macro zone of the country, and see what happened in this case for RSV hospitalization. So this is the third outcome of impact that we are going to review now. What happened with the RSV hospitalization during 2024 compared to the other season? So first, if we observe here in the graph, you can see the bars in every epidemiological week during 2024 in color blue, and compare what happened with this cumulative RSV hospitalization during the season 2024 on bars with the cumulative RSV hospitalization in the non-eligible population, that's mean in the over more than 6 months of age during the season 22 and 23. So in the non-eligible population, we have circulation of RSV, but that was similar to the season 2019-2022. But if we compare what happened with the cumulative RSV hospitalization in the eligible population, that's meaning the less than 6 months of age infants, you can see that on bars during 2024, we see a very, very flat curve compared to the information of the cases of RSV hospitalization in the previous season. And a similar situation is observed if we analyze the cumulative RSV pediatric intensive care unit hospitalization, again in the non-eligible group that we have cases, compared to the eligible population that against the curve goes very flat compared to other seasons. What about effectiveness of nirsevimab strategy in Chile? Here is the table of effectiveness of the RSV prevention strategy in Chile. I would like to emphasize that all of these data will be published during the next week. It will be available, will be released in Lancet Infectious Disease with all the details that we're talking and more if you want to know more details about these results and the strategy in Chile. So first, I think it's important to emphasize that the numbers that were part of the analysis of the effectiveness for the prevention strategy in Chile. In this case, we include all the national data. So that's mean 145,000 immunized infants. In this case, we compare with more than 9,000 non-immunized infants to determine the effectiveness for 4 different outcomes. First, what about RSV-related LRTI hospitalization? The effectiveness was 76%, and you can see the confidence intervals was tight between 72 and 79%. Second, we determined the effectiveness for RSV-related intensive care unit admissions. That was around 85%, with a confidence interval between 79 to 80, almost 89%. But also there are 2 other outcomes that are also important. What happened with all-cause LRTI hospitalizations during 2024 campaign, and you can see here an effectiveness of 66%, and for all-cause hospitalization of 47.9%. If we see what happened with the RSV hospital admission reduction compared to the other seasons, this reduction was between 80 to 90%. But if you read the paper, if we apply more strict criteria for this analysis, the RSV admission reduction was estimated in very close to 80%. And we also were able to determine the number needed to immunize. That's in this case is how many doses of nirsevimab should be administered to avoid one RSV-related hospitalization. And in this case, the number is 35. Very similar to the number needed to immunize, that is close to 30, reported, for example, for the Nirsegal or Galicia experience with the monoclonal antibodies. Also, we are now able to do some other analysis. For example, we were able, because of the numbers, to analyze, for example, what happened if we compare and we separate. We did a separate effectiveness analysis comparing the seasonal and the catch-up group. And in this case, you can see that in both cases, the effectiveness from these 2 cohorts, the seasonal and the catch-up group, is high, but is significantly higher in the catch-up group, probably emphasizing that for a universal strategy of prevention, it's very important to have both the seasonal and also the catch-up group to be as more universal as possible. And another result that we were able to obtain is what happened with the hospitalization length in RSV-related lower respiratory tract infections in the less than 6 months of age infants. So these supposed to be infants, some of them that were hospitalized, and some of them were nirsevimab recipients, and most of the others were non-nirse recipients. So the question here is even they received nirsevimab, the hospitalization length was similar or was significantly different. And in this case, you can observe that in the pediatric ward, NIRSE recipients have a mean of hospitalization lengths of 4.1 days compared with 5.2 in the non-recipient groups, and this was statistically significantly lower. And also in the PICU, the hospitalization length was 4.5 compared to 6.9. Again, the value is significant, so it was significant less. So even they were hospitalized, NIRSE recipients had or showed significantly lower hospitalization rate compared to non-NIRSE recipient infants. What happened if we compare the results from Chile with another experience with the universal prevention strategy monoclonals? And in this case, from the northern hemisphere, from developed countries, probably most of you know the result from health impact of the NIRSE-GAL, the experience in Galicia, that shows similar graphs and a result that RSV-related RSV hospitalization in infants were 89% lower after the nirsevimab implementation compared to previous seasons. And also, in the NIRSE-GAL experience in Galicia, the effectiveness data show a 70% of effectiveness against RSV-related LRTI hospitalization and 80% of effectiveness against RSV LRTI hospitalization that require oxygen support. The difference in Galicia and in Spain is that they had the second season using monoclonals during the season 2024-25. And again, if you see the bars during the last season 24-25, even comparing the results of cumulative RSV hospitalization in the eligible population, they obtain a similar and even a lower cases of cumulative RSV-related LRTIs hospitalization. Another important results are regarding the maternal pre-F vaccine for RSV. Most of the results in the real world and recent data from the RSV pre-F maternal immunization came from Argentina, where they started on during March 2024, a national strategy with this maternal immunization vaccine. They obtained a coverage rate in the target group. It's not the full newborn baby during a year. It's because the seasonality, as you remember that I mentioned, was similar to Chile. So the target for the target group, the final coverage was 65%, and we can observe now the result of effectiveness and impact regarding this strategy. First, you can see the results from the Bernie study that was already published in Lancet Infectious Disease around 2 weeks ago. The first author is Dr. Gonzalo Pérez Marc. And here in this, that was performed in 12 centers in Argentina, is a retrospective case control study with a test negative design. And after they analyzed more than 200 cases and 200 controls, they were able to show a good effectiveness result of 78% in the 0 to 3 months of age infants, and 0 to 6, and in the range 0 to less than 6 months of age, and effectiveness against RSV LRTD hospitalization of 71%. Another study from Dr. Mauricio Caballero in Argentina in a multi-center hospital-based surveillance study, the effectiveness reported was also good, from 0 to 3 months of age of 80%, and from 0 to 6 months of age of 66.1%. This is regarding effectiveness. What about impact? How the reduction of RSV hospitalization during the season? There are data from Argentina also. This is the data from Dr. Caballero. The reduction, the lower RSV hospitalization cases than predicted was around 33%. More recently, like 2 or 3 days ago, there's a paper available from the group of Dr. Angela Gentile from Argentina, multi-center prospective observational study, again with a nested case control test negative, including 91 cases and 96 control in 4 pediatric hospitals. And here you can see that the maternal RSV vaccine effectiveness reported, the crude BI is 68%. If it's adjusted by independent predictors of RSV infection like age under 3 months, history of prematurity, and chronic respiratory disease, the adjusted vaccine effectiveness reported in this study is 78%. So most of the experience from Argentina are showing also very consistent results about effectiveness. So in conclusion, regarding the Chilean strategy, well, Chile was the first Southern Hemisphere implementing a national RSV prevention strategy with monoclonals that really obliterate the need for the year-to-year winter virus campaign. The program provided prevention against overall RSV and PICU-associated hospitalization between 76 to 85% respectively, with an optimal safety profile and with 0 RSV-associated mortality. So I think that our findings in Chile indicate a broader public health impact, with reduction also observed, as we show in the table of effectiveness, in all-cause LRTI hospitalization. And we hope that this effectiveness results, followed by cost-effectiveness analysis that we are continuously developing, should encourage similar countries to advance to RSV prevention strategy. And in general, we are now in an incredible moment for RSV prevention. We have new effective prevention tools against RSV, and the idea, I think, is to use or to implement universal strategies as inclusive as possible, including the bigger numbers of infants that we can. For sure, with these results, the strategy against RSV are here to stay. At this moment, I believe that monoclonal antibody are the base of the strategy, because we can implement a universal prevention strategy using monoclonals or maternal immunization in countries. But in my opinion, this strategy should be complemented if you use maternal vaccine also with monoclonals, because in this way we include preterm and also all the infants that born from mothers that were not immunized during their pregnancy. Anyway, it's important to continue to generate data, evidence, surveillance, epidemiological surveillance, and also genomic surveillance for an adequate decision-making in public policy. And detailed and dynamic analysis, I think, is the best way to decide the best strategy, because each country can have their own epidemiology, their own social determinants. So this dynamic and detailed analysis should be done by themselves to decide what is the best strategy to implement. With that, I also like to give the acknowledgement to all the people that in case of Chile worked a lot and with a huge effort to obtain good coverage and this impact and effectiveness results in Chile, and of course to acknowledge every mother and father who relied on the immunization and the RSV prevention strategy. Thank you very much, and here is the end of my presentation. So thank you.
Thank you, Juan Pablo. Thank you so much for a fantastic webinar. This is exactly what we hoped you would give us. So thank you so much. And this slide is to remind everybody to use the Q&A button so that we can ask your questions to Juan Pablo. I will be your moderator. So I will start off while people mention their questions. So one of the first effectiveness studies that was done with nirsevimab was in Galicia by Federico. And that is a region in a high-income country setting. I think a lot of people were not so sure that this could be recapitulated, could be repeated and confirmed in another setting. But you showed, and I want you to comment on that, that the effectiveness that he sees in a region of a high-income country is actually the same or very similar in an upper middle-income country region in South America. Do you agree? And what differences or complications do you see? And would you be willing to speculate how this translates to even lower income settings like LMICs? And I've seen people in the audience that are actually representing that area. So give us your perspective on expected effectiveness in different parts of the world.
Mm-hmm. Yes, thank you, Luis. Yes, I think this is a very, very important question. But just to start, I think that strategies like this, first is one of the key points of this strategy is the equity. So equity of access, not only in comparing one developed country to another non-developed country, even inside the same country here in Chile, the only way to go for the equity is that this is a state-funded program that includes all the private and the public system. So this is, I think, one first statement that is very important, and the access for that is very relevant. Second, yes, the results comparing Galicia or Spain to Chile are very, very consistent. Chile is a high-income country at this moment. It's not very high. It's not a developed country, but compared to other, yes, it's a high-income country. But it was possible. And believe me, that was very hard. It's a very hard work to try to implement a strategy and like this. That it was possible. I think that, for example, in my region, in Latin America, I really believe that any country can do it. And now, I don't know if all of you know, but Paraguay is a middle-income countries, started a program very similar to Chile, including all newborns during season and a catch-up group of less than 3 months of age that started on March of this year, 2025, in our region. And we are sharing and having contact. We have a lot of contact with the Paraguay Ministry of Health regarding the cost effectiveness studies and how they can replicate experience and now share the data. And I'm very sure that the results from Paraguay will be also consistent with the results from Chile and the results reported from the developed countries in the Northern Hemisphere. So I think that we have the opportunity to replicate this strategy, and the result could be consistent in different settings. The point here is the access, because you know that the price of the product is when you see at the first time looks expensive. In the case of Chile, every dose was around $250,000, around that. But if you see the cost effectiveness analysis, and now that we are analyzing with the engineers and the Ministry of Health the real data of the national campaign that we are not still ready to publish, but we are on way for that. The campaign was cost saving and was very cost saving, not including only the direct cost. Now that we are also including, for example, cost regarding medical leaves that in Chile the state have to pay when an infant less than 1 year of age is hospitalized, not the maternity leave, because all the mothers have, of course, there are no difference for that, because all the mothers have maternity leaves. But these medical leaves that have to be paid because an infant less than 1 year of age is hospitalized, this amount of money that we are analyzing now it's a big support for the strategy of the monoclonals to be also cost saving. So the opportunity is here, and we have to move forward to push, of course, all the groups and the authorities to take the decision, I think.
Thank you so much. We have a few questions in the Q&A. I will ask them in a second. Meanwhile, I want to ask you, you talked about equity, and thank you for mentioning that, because that is very close to all our hearts. Did you see any difference in uptake of nirsevimab in Chile between different socioeconomic background populations? There was a recent paper in Pediatrics, you may have seen it, that in the United States, there is the issue of lower access in lower socioeconomic classes, and I wondered whether that was the same in Chile.
Yes, thank you again for the question. We analyzed this data, and in Chile, 80% of the population belongs to the public health system, and 20% of the population is part of the private system. That is a clear socioeconomic differentiation. If you compare both, there are no difference in the uptake. There are some regions in the country that the uptake is lower, and is mainly in the north of Chile, that is very dry, it's like a desert, where the circulation of RSV is not too high, probably more related with more awareness about the RSV infection than a socioeconomic difference. But it is not a statistical significant difference in the uptake. The only group that was lower was the high-risk group, the same group that received palivizumab. That's been mainly the preterms and the congenital heart diseases. This was the uptake on this group, especially the group during the second season. So probably, again, less awareness of the RSV disease, was a little bit lower, but no difference regarding socioeconomic status.
Congratulations. That's very, very good to hear. It's you live in a fantastic country, Juan Pablo. There are some questions about other effects of nirsevimab. Yolanda and Yasmin, they wondered about side effects, so unpleasant effects of nirsevimab, and indirect effects, so other than you have seen. So maybe herd, something that points to herd immunity. Did you study that, and did you see any effects, herd immunity and safety?
Well, yes, regarding safety, as I show you the analysis that is already now published from the Instituto de Salud Pública, after more than 160,000 doses of nirsevimab, the safety profile is very, very consistent. There are no red flags in the bulletin, and the objective result is there were only 18 SAVIs reported, and only 4 of them were severe, and from them only 1 was finally attributed consistent to nirsevimab, that this was this lymphadenopathy close to the site of injection. So, but I think that this was in the same way that the other monoclonals like palivizumab, that was not very reactogenic, or is not associated, the monoclonals, with a very important adverse event. So the safety profile was very, very, very high. And regarding other effects of the NIRSE, of course, it's very interesting to see the effectiveness for all LRTIs and all cause hospitalization. What is happening there? To explain this, we do not have data at this moment. We are looking, and we are going to have the results regarding invasive pneumococcal disease, what happened with the trends of pneumococcal invasive disease, and because we know that there is an association between RSV and some bacteria with other viruses and other co-infections. what happened with that, but we still don't have information and detailed analysis to have any conclusion. I think that to assume herd immunity with using monoclonals, I think we are not having evidence at this moment for that. Maybe we have to have better explanation before to have a conclusion. I don't know if you agree, because we can discuss about that, but herd immunity, I think, is probably another concept that is not part of this, the results that we are looking at this moment.
No, I agree that herd immunity is not really expected, but you don't know for sure. So it is thought that nirsevimab does not prevent upper respiratory infection. So there is still RSV transmission possible, but as babies often interact with their grandparents in a very intimate way, and these are at high risk, I still think it needs to be studied. And I thought, because you are doing such a large study, the question by Yolanda Penders was interesting to me. I thought, if you have evidence, that would be really important for the community. But I agree, it is not expected. The thought leaders in the RSV field assume that this is not going to happen. So you mentioned the price of nirsevimab in Chile. You also said this is costly. And Javier, he asks whether Chile will consider clesrovimab when it is thought to be similarly efficacious and safe. And can you speculate?
Well, yes, for sure. I think that if there a second provider, a second option, a second monoclonal, that and in the case of clesrovimab, if we see the efficacy results that they already show in the ID Week meeting, in Iguazu RSV meeting, the efficacy results looks very, very good, similar to the results of nirsevimab at least. So to have a second option, I think, is a very good way in order to have a more doses available, and I hope to decrease the cost of the monoclonals if they start to compete each other. In the case of Chile, in Chile now, clesrovimab was already submitted to for the national regulatory agency. So it's the evaluation is on the way, and of course, if we have any opportunity to have access and to have the second monoclonal, there's a very important opportunity probably to have also data from the real world for this product. But we at this moment we're waiting for the approvals to move forward.
Thank you again. You explain it so carefully. Thank you. So how about genomic surveillance? And is there any evidence that the failures of nirsevimab can be related to genotypic resistance? And this is the feeling that you get from the RSV field is RSV immunization, it's a done deal. We're there, it's gone. The disease, like 90% effectiveness, but did you see any evidence of escape? So far, this problem seems to be really small. How about Chile?
Yes, this is a very, very important issue. Some information from France, for example, showed that in the last season, they were able to detect two variants that have this potential for escape for the action of the monoclonal. Of course, there are nothing at this moment, no signal, a significant signal of escape. But this is something that we have to do surveillance for sure. In the case of Chile, the Instituto de Salud Pública is running is a small genomic surveillance program for RSV, but it's ongoing. And now this year, we from our group, we were able to obtain a grant from the state to in the pediatric hospital. In Chile, we have 3 reference pediatric hospitals. For the next 4 years, we're going to be able to do the genomic surveillance of all the of the RSV that are from the cases of RSV hospitalization. So we are going to do the analysis. At the moment, there are no evidence in the world that we have a problem related with escapes, but for sure we have to do surveillance for sure.
So we got a question whether nirsevimab reduces viral load in those who are infected, and to some extent that is related to a remark by my dear friend Chris Gill. He says, well, maybe there might be evidence that RSV prevention or nirsevimab might reduce viral load and incidence of transmission. So I think, as he says, it might be speculative, so feel free not to respond, but maybe you can say something about the viral load in those who were infected with RSV.
Yeah, I think it's a very interesting question, and that's why we also in the same grant that I mentioned, we included we are going to measure RSV loads just to know what happened, and of course regarding different clinical severities, more severe, less severe, etc. To try to understand more this question. At this moment, I think that the monoclonals have a good scenario in terms that we implement the strategy, we avoid the severity, the hospitalization, the cases of death, but we are able to still have RSV circulating in the community. So some children, of course, get infected. We observe that in children, in the non-eligible population, the virus can circulate and infect also children, but the severity is not a problem, because the age group that have the most severity and the highest mortality is very well protected. So let's see what happens with viral loads. We have to do the studies for that. I really don't know. You know, there's some question about what happened at the mucosal level with the monoclonals, or maybe with the viral loads also. So a lot of questions to be answered probably in the next months or years.
Thank you so much. I think we have come to the end of the webinar. So I think you have shown us that RSV immunization with nirsevimab has great potential, or actually shows already great impact in Chile, and has the potential to change RSV epidemiology around the world. And thank you for doing all this hard work and still making time to share your experiences with all of us. For those of you who are part of the listening of the audience, please complete the evaluation form. Please, if you liked it, please share the website of the webinar with your colleagues so that they can also listen to it. And we really value your opinions. If you were an audience in the room, I would like to have an applause for the team, the ReSViNET team, who worked so hard to make this all possible. I can see that you all cheer a little bit for the team. Thank you all. Have a